Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record, and I hope that you picked up program evaluations on the way in, and if you could please fill those out and return those, and if possible, give us any ideas in regards to future topics or future speakers. Today, it is my pleasure to reintroduce Dr. Dan Fulton. As you may recall, Dr. Fulton is an infectious disease specialist. He did his fellowship at the University of Iowa. He has previously introduced us to a fantastic beasts, and today he has kindly accepted the invitation from the CME committee to update us on HIV, and please join me in welcoming Dr. Dan Fulton.
Thank you, thank you, thank you. Hi. Thanks again for having me. I'm really glad to be here. Especially to talk about HIV. The goal today is to go over HIV in a sort of a high-level view, drilling down on some important points. But I think my main goal in talking with HIV today is one, to sort of talk about where we've been with HIV and where we are now, but also to really help us remember and focus on sort of the humanity of our HIV patients. A lot of folks have been through a lot of things, and there's not that many HIV patients in Iowa, so it can still kind of catch us by surprise when maybe we have an HIV patient. And my goal was to sort of balance sort of the science, but also sort of the social aspects of HIV as well. So I'm gonna blast through things. Feel free to ask questions as we go, otherwise we'll hopefully have some discussion at the end. The title of the talk today is Swimming Upstream, a Guide to HIV Management in the Modern Era. I have no disclosures, but I would like to say that any stories about HIV patients in particular have been changed to de-identify anyone. And any photos that you see are photos that are publicly available and have been printed in publications like Time magazine or in public health publications, which we'll talk about when we get there. And let me also say I'm an adult HIV doctor. The principles are the same for PEDS ID, although some of the treatments are a little different. So this is our HIV team, and as I'm sure you recognize, Dr. Arbolu is no longer with us, although there was years when we didn't have infectious disease here, and I really give Ricardo a lot of the credit for rebuilding the HIV program that we have. Otherwise, big thanks to Kristen and Nasreen, our nurses, who are also sort of like clinic mom for a lot of our patients, and then Kelly and Tricia, who keep us all organized. And I also want to give a special shout out to Sunny Thompson, who's our case manager through primary health. She really helps a lot of our patients with a lot of the things that are out of our control. And I'd also like to thank the pharmacy that we work with, the specialty pharmacy NJL down in Des Moines, Student Health, who has really gone above and beyond with our HIV patients and HIV prevention, and of course the big HIV clinics through primary health, especially in Des Moines. And also all of you, because all of you have probably encountered patients with HIV, and HIV is just one little part of their life and one little part of their medical story. And you are really involved in the rest of their life and medical story. So thank you for all the work you do. So I want to start with a personal case. And the photos you'll see are a man named David Kirby, who ultimately died from HIV, and a story was done about him in Time magazine. And it was really one of the first stories that came out in a major publication that told the story of someone who lived and ultimately died with HIV. I had a patient who I had that went through a very similar experience, and it turns out it was my first patient when I was a medical student on the internal medicine wards. So it was 2006. My patient was 32, and he came in with fevers, some chronic diarrhea. He just hadn't been doing well for several months. He'd been losing weight, had lymph nodes that were enlarged, and he got admitted for basically failure to thrive without a real specific diagnosis. He was with his family. He was an ex-Marine and had done some IV drugs when he was overseas. Otherwise, he'd been working and a productive member of society. Young man, 32. And he thought he had just been really stressed and overworked and was just slowly getting sicker and sicker until ultimately he came in. And he had the CT scan that showed lymph nodes everywhere, so people were sort of thinking lymphoma. He had a lot of ascites, which sort of grew MAI, which is a really unusual infection for somebody to have unless their immune system is incredibly weak. And he ultimately had an HIV antibody, which was positive. It took a couple days to get that back, even back 12 years ago. And his CD4 count was 4, which for reference, a normal CD4 count is about 800. So he appeared not unlike Mr. Kirby here, and over the course of the next few weeks, he slowly dwindled, and ultimately he died. He was with his family when he died, and I got to know him really well, and I do think that that was a big part of how I ended up going into infectious disease. So the HIV story, I'd like to just, for context, go back to 1981. This is when it starts in terms of the sort of the public record. There was sort of a report that came out June 5th, you can see, in 81, where a number of young white gay men started getting this really rare pneumonia called pneumocystis, and they all died from it. And right around that time when that was published, somebody else said, well, wait, I have some young gay men who also have this other unusual disease called Kaposi's sarcoma. This is Kaposi's here. It's sort of a purplish tumor. It's a vascular tumor caused by a virus, and usually it's only found in, or back then, in sort of elderly Italian men. But all these young men were getting it, and sort of the initial connection was, well, these are young gay men, so how do we tie this all together? Then after those reports came out, they sort of had a patient they thought had it. He got admitted to National Institute of Health. This was just a couple weeks later, and he ended up dying. And by the end of the year, they had almost 350 cases. Many of those had already died, and nobody knew what was causing this. So over time, 700,000 Americans have died from HIV. And this year alone, the federal government is spending $26 billion to support people with HIV. So just for context, it started really small, and now it's something that even now is a really big deal. So where did HIV come from? Well, what has been sort of figured out through this kind of neat science of epigenetics and tracing back DNA or RNA of HIV is that if you look here in this sort of deep jungle of Africa, right around this area here, there was probably people that hunted monkeys for meat. And through sort of, the butchering of the monkeys, there's a virus that lives in monkeys called SIV, simian immunodeficiency virus, that jumped into the human population through a mutation. Well, then probably just through sexual contact, this virus slowly made its way down this river, thousands of miles until it got to Kinshasa, which is a really big city. Well, it turns out that that the Belgians then were colonizing this city, and they were trying to get all the people in Kinshasa really healthy, so they were vaccinating them against some things that we had a vaccine for, but back then we didn't know any better, and they were using the same needle for everybody. So probably what happened was they encountered somebody with HIV, and basically it was rapidly disseminated to a huge population in Kinshasa, and basically it went from there. This is probably a virus that has jumped into the human population many times throughout history, but it has only been now that population densities are high enough and travel is widespread enough that it's been able to sort of take hold and not peter out like it's done in the past. There's actually been a couple of different events. We have different types of HIV, HIV-1 and HIV-2, that came from different areas but followed these same types of paths. So the HIV timeline really goes back into the 50s when we do have some evidence of some people in Africa that probably died from HIV. This is maybe small for people to read, but I think it's helpful to see that back in 1980 we had just a handful of cases, 15. Then by 1984 there was about 8,000 cases. We didn't actually have we didn't know what the virus was until right here in 84 when the French discovered it. And then finally, we got an antibody test in 1985. Some of the big issues of the time, though, were that because we didn't know what it was, people were still getting blood transfusions, and many people were infected with HIV through blood transfusions, including a young man named Ryan White, who was a kiddo that had hemophilia, and he ultimately actually was expelled from his school when he was diagnosed with HIV because there was so much fear about him being contagious. He ultimately died in 1990, and at that time the federal government started the Ryan White Act, which is now how we get a lot of our federal funding to support people with HIV. Over time, there have been a number of people that have been diagnosed with HIV that are sort of celebrities, Magic Johnson or Arthur Ashe, or the guy from Queen. But in the end, things have moved forward, and starting in 1997, we started what's called heart therapy, which is 3 drugs at the same time. And then I wanted to bring this up in 2003. This was a really big moment for HIV. President W. Bush started something called PEPFAR, which is the President's Emergency Plan for HIV and AIDS, which basically gave billions and billions, $15 billion worldwide, and has probably saved millions of lives in the developing world through basically your and my tax dollars investing in the care of people worldwide. That program continues today, but it is in danger of losing its funding. So as of at least 10 years ago, we had sort of worldwide about 33 million people living with HIV. I thought this was just sort of an interesting story. The U.S. Forbade immigrants who had HIV diagnosed from coming to the United States until just 2010, so just 8 years ago. And there's some interesting history to that I'll let you read about. But this was long overdue. People have had, this was when HIV was very treatable and people were doing very well, and still it was only 8 years ago that we started allowing immigrants with HIV into the country. If you want to learn more, I find this to be a very fascinating book. There's a movie that sort of is a synopsis in 2 hours, but if you haven't seen And the Band Played On or haven't read And the Band Played On, I think it's a great history of many of the social and political factors that were at play as HIV was sort of coming on the scene. So HIV today is different. Back then people didn't survive very long. They were dying. I think, who here has taken care of somebody that died from HIV? I mean, fair number, but I think those of us that are younger and coming in, we didn't see those same patients because treatment was better. So nowadays, the modern care of HIV is what's called the HIV cascade of care. And the way this is supposed to sort of work is it's like a waterfall where there's a certain population in the United States that has HIV. There's our 1.2 million. Not all of them know they're infected. So the first step is, how do you get diagnosed? Well, about 20% of people who have HIV don't even know they have it. Once you've been diagnosed with HIV, are you actually in care? So maybe you've been diagnosed, but you're in denial, or you just never got connected, and so you have it, you know it, but you're not doing anything about it. Then people that get into care, are they able to stay with care and stick with it? Treat their comorbidities of depression or substance use or you name it. And then ultimately, if you stay in care, are you able to get on treatment? And if you get on treatment, are you able to get your HIV to be totally undetectable? And you can see here, this is the goal. This is where we want to be, undetectable HIV, and this is our total population. So we're at maybe 30 to 40% of people getting to where we want them to be. And when I was thinking about the cascades of care, I thought that this seemed like we should just flip it upside down. And the cascade of care, I think, is sort of like a waterfall going down, but it implies that if you just, keep doing what's right, eventually you like gravity follows and you end up at the bottom. But really, we're swimming uphill here. This is not an easy journey. And each of these steps requires a lot of work, and the flow is against us. It's moving us back down towards doing nothing. So I wanted to talk through these points, and this is how we sort of end up for the structure of the talk: the epidemiology of who has it, how HIV actually works, comorbidities that might affect us, the treatment of HIV, and then what happens to our patients that are doing really well. Well, they're going to age, and what is that going to look like? we really are still learning about that. And then even before we get there, prevention. So this photo is at the top of a long river where we are trying to get to, the calm waters of getting over all the waterfalls. But we've got some steps that we have to go through first. So the very beginning, way out there at the ocean when we're just starting. So who has HIV? So this is the global HIV numbers right now. And you can see there's about 38 million people that live with HIV every day. We're having about 2 million new cases per year. And the number of people dying per year is 1.1 million people per year. What you'll notice, and what I think is most important, is that these numbers are going down. And that is a true success if you think about where we've been. This is a really hopeful story. You'll also notice that this number just keeps getting up. If people are no longer dying from HIV, then the number of people that have HIV will just continue to go up until they get to be 80 years old, and then it'll start to flatten out later. This is what the US data looks like, kind of the same graph. You can see a major peak in terms of death in the early 1990s. And then we started active, heart therapy in 95, and you can see death rates went down quite a bit. And the same story. Generally, new cases and deaths are going down. The number of people living with the disease is going up. For what it's worth, HIV was the #1 killer of 25 to 44-year-olds during a few years in the 1990s, and then dramatically decreased with treatment. And I think when people think about HIV, especially our patients that haven't thought much about HIV, what they think about are the early 1990s when people were really dying. A lot of people were dying. And what we need to try and do is bring them forward into the modern era where most people with HIV do very well. This is an interesting project called The Faces of HIV. These are folks that live down in Florida. They all have videos and talking about their experience with living with HIV, but I put this here to remind us that all these statistics of all the millions of people that have HIV, they're all people, and they all have a story. So the Iowa data is interesting. We don't have a lot of HIV in Iowa compared to other places. We have about 2,700 cases. If you sort of drill down, here's Story County. We have about 53 cases here, but even out into the rural areas, Clay County, way up in the middle of nowhere, 7 patients. These ones that don't have any numbers have too few patients, so if there's less than 5, they don't list it. So we have about 2,700 patients here in Iowa, a lot of them in Des Moines. This is our cascade of care, so we think probably 3,000 people have HIV. We've got our 2,700 diagnosed, and we've got about 2,000 there at the end that are virally suppressed. So we're at about 66%. I want to talk about a case. So this is a 21-year-old who comes to primary clinic with fever and fatigue, lymphadenopathy. His CBC shows that he's got a monocytosis, and he gets diagnosed with mono. No other testing is done, and he completely recovers. So if you've heard me talk, I always say know your oats. So occupation, animals, travel, and sex and shooting up, and it's the sex and shooting up that nobody wants to talk about, especially with a 21-year-old who seems like, he just has mono. But don't forget that the causes of acute mono are EBV, most common, but HIV is a monovirus or causes a mono illness. And so if you would have asked him, do you have sexual partners? Yes, men, women, or both. Well, men. Have you had a recent partner? Yes, a couple new partners in the last month. Okay, that's a different story. And all you got to do is ask those questions, and you'll get to a diagnosis. This patient then goes on to live another 8 years, feels a little fatigued and tired, and ultimately ends up coming in with end-stage AIDS with an infection in his brain, and it can all be prevented up front. So sometimes that initial diagnosis is some of the hardest work that we need to do. Here's our year-by-year HIV new diagnoses. You can see these are very stable over the last 10 years. In terms of late diagnoses, we are making some progress here. So the green line is who's coming in with AIDS, and the general trend here is down. So people being diagnosed with end-stage HIV is less. In general, HIV is more in men in Iowa than women. In general, it's being diagnosed in 25 to 44-year-olds, but kind of you can see even over 45-year-olds can be diagnosed with HIV. And as people age, we've diagnosed people that are 80 years old with HIV. Otherwise, in terms of race risk factors, I thought this was sort of interesting. There's been sort of this bump in black folks that are getting diagnosed with HIV over the past few years. We think this is because over time there's been disparities that have been noted in diagnosis, and Iowa has been investing a lot of energy in public health measures to get people tested. And so probably it's not that there's more HIV in black people, it's that they're getting tested more aggressively because of the disparities. These are the sort of overall things. So you can see that black people are being diagnosed at a higher rate compared to their population level. I think that data is a little bit skewed because of the recent testing push. In terms of risk factors, this is important. So men who have sex with men is the highest number of people that are getting HIV. Otherwise, you can see the orange line is people that are using drugs. Green is both MSM and drug use, and then the blue is heterosexual folks. And I think it is important to note that the reason over time that this has been called, or the category is men who have sex with men, is that many of these patients don't consider themselves gay. They may be married. They might have a heterosexual relationship, but on occasion they have sex with men, or they have in the past. And so as you're sort of working through questioning or wondering is somebody at risk, don't overlook the fact that a married male couldn't also be sexually active with another male in a outside of the marriage relationship. This is the U.S. sort of heat map for where HIV is, and you can see that it's primarily along the coasts and in big cities, and not a ton here in Iowa. So this is another case, now just thinking about that epidemiology data that we had. So this is a 42-year-old woman. She went to primary care in rural Iowa, had malaise, diarrhea, fatigue for months. She actually had a leukopenia, low white blood cell count, and low lymphocytes. She was worked up actually here. Again, was diagnosed with idiopathic lymphopenia. She was sent to the University of Iowa, where she was followed for 2 years and basically had idiopathic lymphopenia, low white blood cells. She had no history of IV drug use. She's married. She has 2 children at home, 7 and 10. Symptoms go on for years, all sorts of doctor's visits, until finally she tried to get life insurance. They made her draw blood, and they called her, and they said, "You have HIV." Well, it turns out that her husband had a secret IV drug use problem and had gotten infected with HIV, and she didn't know it. So the point of this story, and this is a true story, is that you can't just rely on typical risk factors. This is a 68-year-old pastor who started having weight loss and diarrhea. He spent a lot of time overseas doing missions trips with his family. No IV drug use known, and because of diarrhea, he got $1 million workup for possible parasites, all negative. No IV drug use, married, children, grandchildren, they'd all do these missions trips together. Ultimately, he got referred to infectious disease to figure out the parasite thing, and HIV test was done and positive, and what happened is he'd had an encounter when he was in Africa with a prostitute, one time. So the point of those stories is to think about HIV even outside the usual risk factors. This is a story that I think is worth telling. Just maybe 2 years ago now, Scott County in Indiana, there was a note that there was a couple cases of HIV that popped up there. Well, 1 or 2 cases didn't catch anybody's attention, but then all of a sudden there was 10 cases that were all diagnosed within a few weeks of each other. So CDC got involved. By the time CDC actually got on the ground, there was 40 cases. By the time they actually got money going and a public health emergency declared, there was 150 cases. And this town only has 2,800 people. I mean, this is 5% of the town. So what happened? What happened was that somebody moved to that town with a HIV that was untreated, was using IV drugs and sharing them with other people, and very quickly, through what we all know is sort of a opiate epidemic, HIV sort of exploded in this very rural small town. I find that interesting because just a few months ago we had a patient move to very rural Iowa, and she had been in Montana. She used IV drugs. She had HIV, but she was not in care. So this is one of those patients who knows they have it but aren't linked to care. And ultimately her relationship ended, and she moved here to a town of about 500. And she ended up here at Mary Greeley with some chest pain, and they heard, okay, so you have HIV, we need to get you linked to care. They called me that night, and we actually got her in the next day, sort of seeing this as a sort of an urgent need. And we got her on treatment, we got her on drug treatment, and we involved the public health department because of my perception that this is an emergency. She follows up, and things seem to be going well. We thought we were doing great. This is what we wanted to do, get her linked to care. Unfortunately, then she stopped following up. Her IV drug use had relapsed. We ended up doing a well-person visit, through public health, and she had sort of disappeared, moved to Arkansas. The point of this story is that it can happen here. It just takes one person using IV drugs and sharing them with other people, and we could have, an epidemic on our hands. So if you diagnose a case of HIV, we always report that to public health. If you diagnose two, or if something doesn't seem right, by all means, we should get public health involved right away. So, and this is just to make the point, if we look at rural areas for Hep C, which is often, travels in the same way as HIV through IV drug use, that the trend is towards more IV drug use right now, not towards less. And I think that's been well publicized in the news. We're doing a lot with opiates here in Iowa already. But just note that HIV travels along with these epidemics as well. So it's important to know risk factors, but remember HIV doesn't read your textbooks and doesn't always follow the usual risk factors. There is a stigma associated with the risk factor behaviors, and so your patient may not actually always tell you even if you do ask. So the point is, if you have somebody that has anything that you think could be somehow related to HIV, or even if they don't, it's okay to check for HIV. I check almost all my patients for HIV. This is how we do the tests. It's a simple blood test, and basically if they've been exposed within the last 2 weeks, the test turns positive because it looks for HIV protein, which shows up within about 10 days or so, right here, the P24 antigen, and then the antibody shows up later. So the old HIV test, we always said, you had to do it about 6 weeks later, and if you're worried about HIV, you have to repeat it 6 weeks later to be sure. The fourth generation test we use now is the false negative window is very short. So if somebody's had an exposure, or you're thinking they're at risk, as long as it wasn't like 3 days ago, chances are your HIV test will be positive, if they have it. So tests for HIV, I pay attention that all pregnant women get tested. So if they've been recently pregnant, that's a clue. Also, blood and plasma donors get tested, whether they want to or not. And I just think it's something that's worth just practice what you'll say, because it's hard to say this sometimes, because I think we all have this sort of stigma associated with HIV and what that means. But I just say, I think we should check this. It's not you. It's just we need to check this, and we'll get it back just with the rest of your tests. And I've never encountered a patient that got mad at me. I've never encountered a patient that said no. They get it, and they're just like, sure, just check it. I know I don't have risk factors, and that's great. So we'll check it, and it'll be negative, and it's done, unless it's positive, and then it's good we did. So let's see. And if your patient does request HIV testing, that is sometimes a clue, even if the testing's negative, that they have risk factors, and maybe you should start assessing those risk factors for why are you worried about HIV, and is that something that's potentially modifiable. If you do check for HIV, make sure you tell your patient that there's a 1 to 2% false positive rate, and you often will need to do follow-up tests to confirm. I always say that too because it kind of gives them a little bit of wiggle room if they do have a positive test that they don't immediately despair. And then if you do, that initial positive antibody that comes back means nothing. It's just a screening test, and then we have to do the confirmation test. So the point is, don't overreact to the screening test. I've had patients that I did overreact, and I told them I thought they might have HIV, and this is how this is all going to go, and then the confirmation was negative, and I felt really bad for making them worry. Also, be ready that your patient is going to have a very strong reaction if you do tell them they have HIV, in part because imagine if it was you. I mean, your whole life changes in an instant. It changes your relationships, it changes your family structure, it changes your general health, it changes your independence. We have had a patient that when he was told over the phone in what he perceived to be somewhat uncaring way, that he immediately went and attempted suicide. Unfortunately didn't succeed, but it's something to just make sure you have a plan for how you'll talk with your patient. And what I'd suggest is definitely call us, and we'll get them an appointment immediately so that you have a plan when you have to talk to your patient about this, that we can get them in same day or whatever. We try to be very flexible getting those folks in. This is what the Western blot test looks like. We'll skip that. So the screening algorithm basically is the screening test. If it's reactive, it doesn't mean anything. We do the confirmation test. If that's negative or sort of, if they say undetermined, but you had this positive, then we try and measure the HIV DNA in the blood. If it's negative, then it's probably a false positive result. If it's positive, it's positive. This Western blot is supposed to be very, very specific. So if you have a positive Western blot, that is supposed to make the diagnosis. I can tell you we've had 2 false positive Western blots in the past 4 years, so it's not 100%. I think that can help your patient as you're kind of getting them from your clinic into HIV clinic, because it gives them just a little bit of wiggle room mentally as they're starting to adjust to this idea that maybe it's a false positive, and then we'll probably confirm it and move forward, but it's not unheard of. Every single person that's diagnosed with HIV remembers the moment they were told. So let's move forward in the interest of time. So HIV is a retrovirus. This is, hopefully you can see this on your sheet. The point of this table is that HIV is transmitted through sexual body fluids and blood, but the actual risk of a single event is fairly low, except for a blood transfusion. So if you get transfused HIV positive blood, your chance of getting infected is 90%. But here's what's interesting. So we have a number of patients who are married. The male is positive, the female is negative after years and years of being married and sexual exposure. And if you look, actually the rate of a single episode of vaginal sex is really less than 0.1%. So what's interesting, HIV actually isn't that good of a virus. It doesn't transmit that well. It just turns out that people have a lot of sex. And so eventually over time, there's this aggregate exposure. It also turns out that people that are engaging in homosexual sex, that does have a higher risk of transmission. So that's probably part of the reason it's been more of an issue, at least in the United States, for folks that are gay. In Africa, this is much more of a heterosexual illness, interestingly. And that probably has to do with increased transmission in heterosexuals who are malnourished. So they're more likely to not have the initial defenses against the original HIV infection. So this is a point that we'll circle back to this, but if we don't, if you have an HIV patient who's in the hospital or in clinic and they're uncontrolled, they have 1 million copies of HIV in their blood, remember, this is only transmitted through blood and sexual body fluids. So if they sneeze on you, it's not an exposure. If they cry on you, it's not an exposure. So no special precautions are ever needed beyond just usual precautions. So PTs, if you've got a patient that you're working with HIV, usual precautions. You can't catch HIV from somebody unless you stick a needle in them and then stick it in you, or there's sexual exposure. This is how the virus works briefly. So the virus packages RNA It's got some other proteins in there. It meets up with the CD4 cell. It injects the proteins and the RNA. Retrovirus means that it has to then make its RNA into DNA. So it uses a enzyme called reverse transcriptase. Then it uses something called integrase to put that DNA into your DNA. Then that DNA gets made just with the rest of your DNA, and then that all gets packaged up and put into a new virus, and off it goes. That becomes really relevant when we start talking about treatment. If you don't remember anything else about how HIV works, this is a really important slide to remember. So when somebody gets infected, they have no HIV in their blood, and rapidly over the course of weeks, they get up to 100 million copies of HIV per milliliter of blood. During that time, they might develop an acute syndrome of feeling sick or getting mono. But rapidly, the body starts to fight back. It recognizes this as a pathogen, and the HIV RNA in the blood drops to very low levels. The CD4 cells take an initial dip, but then they recover. But over the course of time, the body isn't able to totally get rid of the HIV. It slowly is killing CD4 cells. The body can't make new ones fast enough, and the total CD4 count drops. This, on average, takes about 8 years before somebody's immune system gets weak enough that they actually start to feel sick. However, it's important to note that how fast this process happens depends on what's called your viral set point. So everybody's different. Some people, after they initially get infected, their viral set point is up here. It's really high. Their CD4 count will drop they'll go from normal to AIDS in less than a year. That happens. It happens the other way too. Some people, after they get infected, their HIV is almost undetectable. Their bodies are naturally able to totally control this thing. They're called elite controllers, and their CD4 count may never go down. They might actually be able to live forever. Their body can just deal with the HIV. As your immune system gets weak, that's when the CD4 cell, who's supposed to be sort of the coordinator of your immune response, it doesn't do its job, and you start getting these unusual types of infections and feeling sicker until ultimately you just can't keep up. This is sort of the same thing. It says it differently. So this was a 19-year-old, fever, sore throat, lymphadenopathy, rash. Somebody checks in HIV in addition to looking for mono. HIV was positive. So what was his main risk factor for HIV? Well, he came to Iowa State. He'd never been sexually active before, and he was when he got here. He didn't use condoms because he didn't think he needed to. We asked him if he knew what HIV was, and he was sort of vaguely aware of HIV, but really couldn't tell us anything about it. Really couldn't tell us much about safe sex either. He got HIV because of a lack of education. In his town, they didn't get any sex ed at all. They had no idea. And study after study shows that the more we provide sexual education to children, or I guess adolescents, the less likely they are to participate in behaviors that will get them sick. In terms of this acute retroviral syndrome, about 50% of people remember getting sick. 50% of those seek care. So just because you're sick with the flu and lymph nodes doesn't mean you're going to go in. Of the 50% that seek care, only 50% are actually tested for HIV. It gets back to that original case. People just aren't thinking about it. But if you had to say, I mean, it's generally a mono-like illness. Fever, lymphadenopathy, malaise, often rash. I think it's the rash that often sort of triggers us to say, okay, this is more than just the usual. So that's sort of that primary illness. This is a patient who was referred to hematology because he had low platelets. He felt fine. He was in a long-term relationship, had a 1-year-old at home. Part of the usual evaluation for low platelets was HIV screening. His was positive. His partner was negative. The kiddo's negative. They've been together for years. But he had another partner 6 years prior. So that was probably his risk factor. So common signs or symptoms where you might want to think about HIV, even if it's not kind of the reason they're there. Symptoms would be chronic diarrhea, chronic weight loss, lymph nodes that aren't explained, seborrheic dermatitis that seems kind of bad for somebody who's otherwise shouldn't have that, ongoing fatigue, or if they just seem like they get really sick when they get infections. Labs that should catch your attention would be low white blood cell count, low platelets, a protein albumin gap of greater than 4. So if their albumin is kind of low but their protein's kind of high, that tells you there's an extra protein in there somewhere. HIV would be worth checking. If they get any unusual infection, that's something that's worth checking. Or if they're just getting really sick, like they get zoster meningitis. They're a healthy person. Like most people don't get zoster meningitis, so just check an HIV. It'll probably be negative, but if it's not, you'd want to know that. And obviously, if they've had STDs in the past, you should check for HIV. AIDS is defined as less than 200 CD4 cells. Normal is about 800. There is a range, actually 200 to 1,200, depending on who you are. It might be your normal. This was mostly a historical thing because it mattered for prognosis before we had treatment. So if people had AIDS, they could qualify for disability, and their prognosis was less than 6 months to live. Nowadays, people who get diagnosed with AIDS, often their immune systems completely recover with treatment. But over time, these are some of the diseases that are associated with low CD4 count, specifically pneumocystis pneumonia, fungal infections like we see here in Iowa, and then toxoplasmosis, and then you remember my original patient had MAI. There is some prevention that we can give if their immune system is this weak. I won't trouble you with this, but basically depending on how weak the immune system is, you have to add on more and more preventative medications. Also, HIV is associated with a number of malignancies. So our oncologists are very familiar with these, and HIV is part of the screening process. Generally, if somebody comes in with like a diffuse large B-cell lymphoma, although I have had 2 patients that had been diagnosed with lymphoma, treated for lymphoma, and ultimately diagnosed with HIV later because they just never had that screening test with this disease because they didn't have sort of the traditional risk factors. So just remember, if you're finding lymphomas, it's probably worth checking for HIV. And then this is the other thing. Over time, non-HIV related cancers are increasing because HIV patients are living longer and they're just getting the cancers that everybody else is getting. You can see this is the HIV population in general. So back in the early 90s, nobody was over 65. Now, about 15% of our HIV patients are over 65. So just reorienting, so we've kind of talked about all of this. Let's start talking about treatment. Sometimes treatment seems like just that extra bear in the way. It's adding another problem to a problem. But this is a multidisciplinary approach. Everybody gets involved in this, and we pay attention to all the other things about healthy living in the meantime. But ultimately, it is about the medications. The reason we treat is if we can bend this HIV or the viral set point down to 0, if we can make that undetectable, then the rate that the CD4 count comes down will stop, and if it's actually 0, the CD4 count will go back up again. So we've had people that were way down here at 4 CD4 cells that are now back up at 800 after the virus has been suppressed. The other thing is that if you treat somebody with HIV and you can make them undetectable, they can't pass HIV on to somebody else. This has been shown in some very big studies in Africa where if you wait to treat versus treat immediately, we can show time and again that people that are on treatment don't pass HIV on. So we're breaking those links in the chain towards future infections. And so we actually think we might be able to eradicate HIV if we could just get everybody on treatment, because then nobody else will get it. When to treat, there used to be debate. We thought that we had to wait until their immune systems were already weak. Again, their big studies have shown that if you defer or wait to start until their immune system is weak, they run a much higher risk of death and catching really unusual infections. The reason you might want to wait is these drugs do have toxicity, they do have costs, and there's a risk of resistance the longer they're on them. But right now, there is consensus that everybody with HIV gets started immediately. For a number of reasons, mortality and other negative outcomes. So who to treat? Everybody. We've even had studies now that show that the moment you make the diagnosis, you should start them on treatment, especially if they're in the acute phase of HIV, because that virus is going out to all their lymphatic tissues, all their lymphoid CD4 cells, and the sooner you can stop that process, the less virus they have, and the fewer immune-related dysregulation problems they'll have. There was a baby who was diagnosed just 30 hours after birth. They started the baby on HIV treatment for 2 years. They ultimately stopped the treatment because the question was, well, did we cure this infection? Is it actually gone? The baby had undetectable HIV for several years, and then later it was detectable. But they were able to decrease that reservoir enough that they went for years without even detectable HIV. So we're going to treat everybody as soon as possible. This was a 25-year-old who came in. He's been feeling fine, had HIV screening. Last HIV screening was 4 months ago. This one is now positive. He's not too worried. He knows HIV is treatable. He'd like to have 1 pill a day. He'd like to come in twice a year, and he plans to live a normal life. That was a true story. These are the people that discovered HIV over at the Pasteur Institute in France. I feel like when they were doing their original work, if they knew that we would come to this point, they wouldn't have believed it. But this really is where we are at with HIV treatment. So our treatment principles are HIV mutates rapidly, so patients always need to be on 3 drugs at the same time so that they can prevent the emergence of resistance. We want to completely suppress the virus. Once it's suppressed, the immune system gets stronger. Fewer pills equals better outcomes because they don't have to take as much, and less toxicity equals better outcomes because you're not having toxicity. We also check for any resistance in the virus because this is the population of the virus is very different because it mutates, and so each virus is unique. So we always make sure we know what it's resistant to and what not. So these are all the treatments that are currently approved for treatment of HIV. We have 31 different options, and if you put them together, we have over 100,000 potential combinations of treatment. These are the years that these drugs were discovered. So AZT, the original drug, you could see that's the only thing we had from, this was originally came on 1981 was when this all started. We only had 1 drug until 10 years later. These drugs were terrible. They caused pancreatitis and mitochondrial toxicity. We finally started getting some better drugs. This was about when we started using drugs that seemed like they actually worked and didn't have terrible side effects. This was a game changer called Atripla, 1 pill a day, no side effects or no major side effects. And then over the course of time, we now have a number of other 1 pill per day options. This is an interesting slide. This is the expected life expectancy of a person diagnosed with HIV. You can see back here, your expected life expectancy was 3 weeks from when you had an HIV diagnosis in 1985. As time went on, this is interesting, the Ryan White Care Act was in 1990, and that alone, even without any new drugs, really helped people because they had access to care. But now, we estimate that people with HIV may actually live longer than people that don't have HIV. And the reason is that they see a doctor every 6 months. We talk to them about their smoking, we get their colon cancer screening, they get their mammograms, they get all of the preventive care that we know helps people, and we think that the virus is basically a non-issue if we can keep them on treatment. This is the old treatment regimen. It was about 20 pills a day. And this is sort of, I'm going to skip that. So in terms of medicines you may actually see, I've blacked out the ones that you may actually see people on, but we're going to take it a step farther. And nowadays, these are the drugs that actually get used. And if we took it a step farther, these are our 1 pill per day regimens. We actually have 5 basically first-line therapies that we can use that are 1 pill per day. The principle of therapy is, we're using 2 drugs. So we use 2 of these plus either one of these, or one of these. These always come in combination, or these always come in combination. So either we're using this plus that, or this plus that, or that, or that. So even though there's greater than 100,000 potential combinations, I don't mean to give away our secrets, but it's not actually very complicated anymore. The treatment's pretty straightforward. In the interest of time, we're going to skip through some of the details here. But the goal is to get the patient to here. There's no more rough water. And you can see up at the top, this patient has been undetectable going back for years. And all she has to do is take 1 pill per day, and that's it. The virus is no longer an issue. It's not affecting her immune system. She is otherwise well. So let's see. This is another, this is an important one. This is a 25-year-old who lived in rural Iowa. She came in with right lower quadrant pain, nausea, low-grade fever, and a CT scan showed an inflamed appendix. She had appendicitis. She's on treatment. HIV's undetectable, CD4 is normal. We got called at 2 a.m. by the hospital because the surgeon refused to take out her appendix because she had HIV. They felt that she had to be in an HIV specialty center that could treat her HIV. And I think the point here is that if the HIV is undetectable, whatever other health issues your patient has, you just treat those health issues the way you need to treat them. Whether it's a surgery, they can get surgery, they can get their hip replaced, they can get whatever they need. They don't need anything in particular. And this is big news for us that finally the WHO and the NIH have officially said that if you are undetectable, you cannot transmit virus. So imagine being a patient and hearing that information. Imagine, being married and you've got a spouse. This has huge implications for family planning for our patients. They used to be able to not have children because they didn't want to transmit virus to their partner. If you have undetectable virus, you cannot transmit that virus. You could probably even get a blood transfusion, and it wouldn't matter. So we already talked about this. Standard precautions are all you need. There's nothing in particular about that. Let's see. So, sorry, it's taking a long time. So those are our take-home points. And the life expectancy thing we talked about. The future of HIV treatment is probably in injectables. We're getting to a point where we'll probably give people an injection once every 8 weeks. So rather than having to take a pill every day, we've got long-acting injectable medicines. This is how most HIV treatment studies go. They sort of measure how long did we suppress the viral load, and almost all studies now are in the 95% realm. These are not yet commercially available, but I bet they will be, and they'll help us sort of capture those folks that have a hard time taking medications every day. The HIV population is aging. They suffer from higher rates of almost everything. So higher rates of hypertension, coronary disease, COPD, non-AIDS cancers, dementia. We think that people with HIV, especially if it's been uncontrolled for any length of time, suffer from a chronic inflammatory state. So they basically rapidly age. They have higher rates of every age-related thing you can think of. So that means that we need to do an aggressive job of all of our usual screening. Sorry, this is so small, but all of our cholesterol, all of our blood pressure, all of our tobacco, all of everything needs to be just really aggressively done. And then we just pay attention. All usual vaccines are okay as long as their CD4 count is over 200, which is almost everybody. Live viruses you can't give to people with a CD4 less than 200. If you've ever heard of an HIV cure, there was one guy that was cured of HIV. To do that, he had to get AML. He had to get a bone marrow transplant. His AML had to relapse. He had to get another bone marrow transplant. And at the end of it, when he came out of it, the HIV was gone. That's not a good treatment plan. So, for now, HIV is not curable for a number of reasons. We do have some hope that a vaccine is going to come available. We actually have a major trial going in South Africa right now that some of the prelim data shows maybe 30% prevention. They've since changed that around a little bit, and we're hoping that this could be a preventable illness within a few years. This is the last big topic we'll talk about. So pre-exposure prophylaxis. So we know that certain people are at risk for HIV, specifically our folks that are men who have sex with men and people who use IV drugs. The U.S. Preventive Service Task Force just came out with a grade A recommendation that people in those categories should be on preventative HIV medicines. So Truvada is a one pill once a day. It has 2 medications in it, and it turns out that if you take it, it prevents HIV transmission 90% of the time compared to placebo. So at this point, even people that are at high risk, we should be able to prevent HIV. I wanted to give a big shout out to the Iowa State folks because we were doing their preventative treatment for a while. We did a couple in-services there, and now they've completely taken over that program. They're not needing, an infectious disease physician to do that. I think that's the future, because if we were to offer pre-exposure prophylaxis to everybody that could benefit from it, there's just not enough ID doctors to go around. So kudos to the university for really owning that and taking it over. If you're interested in doing that, if you have a population of patients that you think might be at higher risk based on your work, come talk to me and we can talk through how the program works, and you'd be very capable of doing it on your own. It just requires sort of regular screening, some talking about toxicity, but in general, we can prevent HIV, and we should have no new HIV cases in Ames, Iowa. Some people want to be on it just because they're nervous. Condoms work too. So I mean, I think if your patient isn't highly sexually active and they're using condoms regularly, it may not actually benefit them. So just having a history of having chlamydia once doesn't mean you need to be on a medication. But what I tell my patients is Truvada isn't cheap. I mean, you have to pay for it. But most of them are going through a particularly high-risk period of their life. And they're going to age out of that. Their brains are going to fully develop or whatever. You know, I mean, like, they're going to get to a point where they don't need it anymore. They'll get into a monogamous relationship, whatever. So we sort of use this at a highly focused time. We break that chain of infection, and then 20 years from now, we don't have any new HIV cases. So I think if we all work together, this sort of flow towards entropy and patients not being in care, we can keep people where we want them to be, get them on treatment, get them suppressed, no more infections, and HIV will become sort of a thing of the past. So with that, I'd like to open up to questions, and thank you for your time and attention. Yes?
Yeah, have you had a problem getting insurance coverage for Truvada?
Great question. No, actually. And actually what I tell my patients is, especially with the private insurance, they just Google Truvada coupon, and Gilead gives them the coupon for their copay, not because they like them, but because then the insurance company turns around and pays Gilead for the rest of it. But even our Medicaid patients, we've had coverage. And I should also note that HIV treatment, compared to the way it used to be in the 90s, getting these treatments, right now, a Medicaid patient in Iowa with HIV, we can get them the newest cutting-edge treatment because the public health side of things shows us that if they can take a treatment that they can actually stick with, that actually works, it will decrease our long-term costs because there aren't any new infections in the future. So the whole idea, I think, that insurance companies have gotten is we're actually saving money in the long run by preventing new infections. Good question. Yeah, Dr. Kitchell.
You mentioned that there was maybe some risk of losing the international money to treat HIV. The Ryan White is only U.S., though,
That's right.
Is that right? So
Yep.
if the international money goes away, hopefully the Ryan White won't.
I've not heard any risk to Ryan White that I've heard of. And like I said, our patients, I feel like, have excellent access to resources. I think it's just people that remember the 90s when young, healthy Americans were dying. Fortunately, those are the people that are now sort of running the programs. I think the risk is the longer HIV is not in the public eye, we almost become a victim of our own success. You know, people with HIV do great. What do we need to be investing all this money for? Well, if we don't, then we go with the flow, and the flow is towards not being on treatment, not being in care, and young people dying. So at least for now, Ryan White is a robust program that's well supported. It's PEPFAR that's been cut.
I presume it's the politicians that are the right-to-lifers that are probably going to cut those international funds.
You know, I don't know about that. The original PEPFAR did require that a third of the money had to go towards abstinence-only programming, which studies have shown probably isn't very effective. My take is the more the merrier. You know, if that's what it takes to get the funding where it needs to be, then let's just do it all. That's fine. But I'm not aware of any particular person pushing for. Nobody wants to not treat HIV. I think it's just that it is expensive, and we're sort of in an era where, you know, America's politicians are looking more inwardly, and so any extra funds going out are kind of being cut. But I don't perceive that it's an agenda-driven thing, because I think in general people recognize HIV needs to be treated. Yeah. Mm-hmm. Yeah.
thinking about whether or not it's worthwhile to teach them how to circumcise.
So yes, so that is well studied, and being uncircumcised is a definite risk factor for HIV transmission, even among heterosexual sex. So, and the rate is actually included in that one slide, if we could go way back, where I forget what the actual numbers were, but it's dramatically less. So in a place that has a very high prevalence of HIV, I would see that as a public health measure to circumcise. Good question. Yes. In general, yes. Yep, in general, PrEP is being covered. I think copays are higher, but especially for private insurance, which most of these folks are young and healthy and pretty engaged, there's coupons to pay for the copays. I should also note, because it has been sort of brought up out of concern, like, are we giving people license to be irresponsible with pre-exposure prophylaxis? And the answer is actually no. People that take the time to come and get preventative Truvada, studies have shown they're actually more likely to have fewer sexual partners and use condoms more consistently. One, there's probably a selection bias because they're responsible enough to come get the treatment, but two, they have to see us regularly, and we're constantly hammering home, this is what, safe practices look like, and please remember there's other STDs aside from HIV. This only prevents HIV. You could still get syphilis, which you really don't want. So anyway, I think the studies show that people that use PrEP are actually more responsible and having less sex than people that aren't. Anything else? Okay, thank you. Thank you.